I had gone to take a lecture in Indian Fertility Society में एक lecture लेने गया था Indian Fertility Society की annual conference में, and I was given an invited lecture for a master class. मेरे को invited lecture मिला था ये बोलने के लिए कि जो लोग एजोस्पर्मिक होते हैं, जिनके स्पर्म नहीं होते, उनके स्पर्म रिट्रीव करके उनका बेबी कैसे दिया जाता है. ये पूरा लेक्चर मैंने लिया वहाँ पर डॉक्टर्स के लिए. आई ऑलवेज गो टू ट्रेन. पिछले 12-14 साल हो गए मैं हर जगह लेक्चर लेता हूँ. जिनके स्पर्म नहीं होते उनका स्पर्म लेके उन्हीं का बेबी कैसे किया जाए, उस पे पूरे लेक्चर्स लेता हूँ. ये पर्टिकुलर लेक्चर मैंने इंडियन फर्टिलिटी सोसाइटी की एनुअल कॉन्फ्रेंस में उन्होंने इनवाइट किया था, वो लेक्चर लिया. इस लेक्चर को मैं पूरे को डाल रहा हूँ यहाँ पर इसलिए बिकॉज अ लॉट ऑफ डॉक्टर्स विल लाइक टू अंडरस्टैंड व्हाट टू डू, अ लॉट ऑफ IVF स्पेशलिस्ट विल लाइक टू नो एंड अंडरस्टैंड व्हाट टू डू. और मैं अपने पेशेंट्स के लिए तो सिंप्लीफाइड बनाता ही हूँ, बट आई वॉज वॉन्टिंग टू मेक दीज लेक्चर्स फॉर एवरी डॉक्टर who should listen to it and understand what exactly we need to do. So I go ahead now for you because this is one of the most beautiful training lectures you could get. So first of all, likha hai. First of all, thank you very much for being here, and Dr. Nair, thank you very much for being the chairperson today. The reason is I am going to today whatever I know in the last 30 years and doing micro-TESE for the last 14 years. I'm going to just put everything in video for you to understand, because understanding Azoospermia is different. I only have 15 minutes and 14 नहीं 15 मैं अरे सर नहीं होगा ना, नहीं होगा, हो गया. Oh wow, fantastic. So now before we do any procedure in any patient, we need to be sure of one thing, whether it's an obstructive azoospermia or it's a non-obstructive azoospermia, because whatever you're going to do will be determined by obstructed or non-obstructive. So in obstructive azoospermia, you're going to have normal spermatogenesis, mechanical obstruction of the reproductive tract, and 40% of azoospermic cases are obstructed, 60% are non-obstructive. Now, non-obstructive azoospermia primarily is primary testicular failure, secondary testicular dysfunction, or it could be a mixed pattern. So you get a lot of patients who have a normal FSH, a normal size testes, but when you realize and try to do a PESA, you don't get a sperm. So this is a mixed pattern which is based on the level of spermatogenic failure in different areas of the testes. Now let me explain to it before I go on to the procedures. Have you seen an apple tree? Say yes. आम का देखा है, apple नहीं देखा तो देखा है ना? So that greenness is the testes and focal spermatogenesis is the fruit on it. So if somebody comes to you with an FNAC and says, I have spermatogenesis, you have to be very clear in your mind. It doesn't matter if there is no spermatogenesis. If there is spermatogenesis, yes. But if it is negative, it does not mean that sperms cannot be retrieved, because in these patients, it is going to be focal spermatogenesis. Now, what are you going to examine? You're going to examine 5 things in the male: secondary sexual characters, testicular volume, palpation assessment, varicocele assessment, and digital rectal examination. Before any patient who undergoes any kind of sperm retrieval, you've got to do these 5 things. Now, what investigations would you need? You would need an FSH, you would need an LH, you would need a total free testosterone, inhibin B if you want to get it done, prolactin and estradiol. Genetic testings 2, a karyotyping and a Y chromosome microdeletion. And semen analysis, you're going to see 3 things. 5 things in the examination and 3 things in the semen examination. The volume, if it is less, it probably is obstructive. I mean, there is some ejaculatory duct obstruction or hypogonadism. pH assessment between 7.2 and 8. And in case it is negative and there is an ejaculation, you may need to do a post-ejaculatory urine analysis. Now, key parameters to differentiate obstructive azoospermia from non-obstructive azoospermia, though let me make one thing very clear to you. Very clear to you. You get a lot of patients which are midway. You may think this patient is obstructive, it doesn't turn out to be obstructive. So when you counsel a patient, you have to be very clear in what you tell them. So in obstructive azoospermia, you're going to have a testicular volume normal, FSH normal, ejaculatory volume may be reduced, testicular consistency normal, and success rate is 90 to 95%. Maybe less in a few patients because the quality of sperm may be down in a few cases. Obstructive azoospermia, testicular volume often reduced, FSH level often reduced, ejaculatory volume usually normal, testes may be soft, and the retrieval may be 45 to 65% if it's a maturation arrest and hyperspermatogenesis. If it's a Sertoli only, around 20 to 30% retrieval. Now, I'll go into the surgical management over the decades. The first era was when TESA came up and conventional TESA was done. Second came when in 1999 to present, Peter Schlegel did the first in 1999, Micro-TESE till present. And in the future, there's going to be artificial intelligence and novel visualization technologies about which I'm going to talk over here now to you. Now, first of all, let's come on to the PESA. The advantage of a PESA is that you could get 80 to 90%. My videos are not running. I told you to upload the whole. Chal gaya? So, what you're going to do over here, what I normally do is instead of using a BD syringe, what I use normally is a butterfly. You have better control over it. You use a butterfly, you take media into the syringe, and when you have done a PESA, you are going to give a pressure. With this pressure, you're going to clamp and take it out. Now, the interesting thing about this is now, because I do microsurgery, I do a lot of patients in which I do a MESA. MESA means I'll open up the epididymis, put in a angiocath into a tubule, into the epididymis, because I'm able to get a lot of seminal samples, a lot of sperms, which I'm able to freeze for a couple of times. But in case you do not do microsurgery, PESA is a good option. The only problem with PESA is that once you have disrupted the epididymis, it will never be repaired. Like one major problem which you should never do. In any patient of non-obstructive azoospermia, please do not put a needle into the epididymis. The moment you put in a needle into the epididymis, if in the future there were any chance of spermatogenesis, the semen sample is going to be azoospermia. So never put it. A lot of people open up the testes, put a needle exactly into the epididymis. In non-obstructive azoospermia, don't do it. That's the best option. Now, the second comes is a conventional TESA. Zara video on kar dijiyega, please. Yeah, ho gayi. Now, conventional you can do very simple. All that you need to take is a small piece of tissue. And the tissue requirement normally is 50 to 100 milligrams at times. What happens? You could have, not in this, but a multiple approach. A lot of people take multiple biopsies. You can, in these patients, have testicular atrophy and hormonal dysfunction. Success normally would be about 20 to 30%. Now, microsurgical testicular extraction. Now, the technical principle is simple. You've got to look for some tubules under a microscope which probably would be having any kind of sperms, number one. The advantage is it minimizes the tissue damage. Number three is it preserves the testicular architecture. And the fourth is the sample is less but optimized to retrieve more sperms. Now, why it is good? Because you can retrieve sperms in 50 to 70%, and the live birth rates, if you get good sperms in the young woman, could be up to 40%. Now, pre-operative, what do I do? I'm going to bring to you what do I do. So first, I'll confirm whether it's non-obstructive azoospermia. I'll definitely have a karyotyping, Y chromosome microdeletion, endocrine profile, and scrotal ultrasound to guide me. I do scrotal ultrasounds myself, so I know exactly what is the best person vascularity with vascularity and the consistency where probably would be the best place to search. If there is any hypogonadotrophic hypogonadism, I'd like to give HCG or clomiphene to get the testosterone up. And I would consider an FNA mapping, which I'm showing to you over here. Now, what happens in FNA mapping is you divide the testes into 16 areas, 8 above, 8 below. You put in a thick needle, and after you've put it in, a seminiferous tubule will come out. you just start pulling out those seminiferous tubules with a microforceps the way I'm showing. So the amount of tissue which you get out, because it's a single chain, it's not that छोटे-छोटे pieces होते हैं, it's a single chain which can be pulled out. You can get a lot of tissue, and in case you get it in this tissue and suffices, you won't have to open the testes. But if you need to open the testes, you probably are going to open the testes in the area where you have got these retrievals. Now, I'm giving you the key steps. Anesthesia, maintain the scrotal temperature about 35 to 37. The temperature in the OT should be around 21 to 24. Exposure should be 1.5 centimeter mid-raphe, parallel to the vessels. You can see over here that everything which you have in terms of the test tubes and everything would be also maintained at 37 degrees centigrade. You would give a straight incision. Why? It's an invisible scar, number one. Two, there are very little hematomas. Once you've done this, what I normally do is I use a microdoppler, which I normally have, which I use for my varicoceles. This gives me an idea which area would probably be having vessels which I don't get into, because I don't want any bleeding into the field. The next thing is that I normally do all the surgery at about 25x. 25x is the maximum magnification which I possibly could get, and this is what I'll use. Now, once you have opened the testes, I would normally sweep it in 3 stages. The first is the superficial stage, where I'm going to sweep from the superficial stage. The second would be the deeper stage. As you can see over here, I would open it up. And the third would be the tissue quantity. I would normally take out very small pieces of tissue, only 10 to 20 milligram per side, because testosterone recovery is very good within the next 6 months. I don't have much time, so now I'll get you 2 things into it. Number one, unilateral masses, bilateral. When I started this procedure, I would be spending about 1.5 hours on a testes, but today I'm clear that if I get it in 30 minutes, fine, otherwise I go on to the next testes. The shorter the operation time would be, fewer complications, but then it takes time to learn the procedure. The second is the intraoperative biologist. I normally have 1 or 2 people working all the time getting the samples, so that the moment they tell me they've got a sperm, I could send them more tissue from the area they think that sperm has been there and call it a day. And this leads to less time, less exposure. The next is, now what I do normally is I have a phone over there in the lab. I just have a WhatsApp video calling like I showed. Now what I normally would do in a micro-TESE as I show over here, because I just have 3 minutes. 3 minute के बाद में 2 मिनट और हैं? 3 मिनट के बाद में 2 मिनट और हैं? हाँ, चलो. अब इसके अंदर what I would normally do is I would open up the testes, and this is the first stage. The moment you open it up, you would like to take out whatever tissue is there. Now I'll show you some pictures. Some pictures of the magnified pictures of the way the seminiferous tubules are going to look. If you see over here, this is an area where, just look at, these are different tubules from those tubules. And this amount may be looking a lot under a microscope, but actually it's a very, very small amount of tissue. Can you judge and see over here, these tubules look thicker, yellowish, swollen. And this is one area which I would remove. So what you would do is you would scan the testes in 3 stages. First, open it further. Second, open it further. The third area. See over here, if you can see, these tubules are different from the, and thicker tubules than the tubules which are seen otherwise. Gaurav, can you take a few pictures of mine, please? Sure. Yeah. So if you see over here, this is another area. And just look at this tubule. I'm just showing you how to identify a tubule. If you see this tubule, this is a tubule which probably would have, now just see this. This is a sample of a micro-TESE, and this is a sample of a conventional. And the tissue I have taken out in a micro-TESE would probably be more identifying and representative of the spermatogenesis area. Now, how do I do it in the lab? Now, this is what, if there must be embryologists and clinicians, I just want to show you. So what we normally would do is use it temperature controlled. Now this temperature control which we need over here has to be 37 degrees centigrade in terms of even the buffer with 5% albumin. Mechanical mincing is the standard which is done, as you can see over here, using a fine needle until no intact tubule remains. Now, I would also tell you about the enzymatic. Now, supposing you have done the stepwise mincing, you've tried, if you see over here, this is the kind of pulverized tissue is going to look. You could use collagenase 4, which we use, with DNase 25 microliter per ml in Hepis media for 37 degrees centigrade, and we agitate it gently for 30 to 60 minutes. And we have realized that in patients in whom we have not been able to find a sperm by mechanical mincing, of course we try it first, then we put the patient onto this, and the recovery of sperms becomes much better. Now, the moment you find it, you would like to normally get the sperm. A lot of people use an erythrocyte lysing. We don't. And we don't use it because, Gaurav, you will get it very clearly. If you see over here as well, in the background of the RBCs, the sperm is visible better, especially if it is motile or has a slight motility. And this is an area into which, it becomes a background of cells. And this becomes very useful. If the count is more, you could do a density gradient or a microfluidic in these patients, and that could be very helpful. And these are the sperms which actually found rarely could be used for an ICSI. Now, cryopreservation in low numbers. Earlier it was conventional sperm freezing. Now we do a vitrification of a lot of sperms. Especially you get a lot of small, small aliquots into which you could freeze them, which could be very useful, because every sperm which you get, if frozen, and the patient doesn't get pregnant, you don't have to take the patient again into a micro-TESE or a TESA or a PESA or a MESA, PESA especially. So it becomes very good to cryopreserve them. Now, I would talk about the predictors. In the histology, if you get late maturation arrest, you can get sperms in up to 70% versus 40% in early maturation arrest, or even 30% at times. Now, the testicular volume is a good predictor, but not a great predictor. But if the volume is more than 8 ml, it favors micro-TESE, always in any case. And FSH, though you get in, I have, I think, got sperms in an FSH of 112. So, that's what I have got them in. It really is a predictor, but you do not stop a patient from being put under a micro-TESE because of the FSH. A positive FNA mapping is great, and it all depends on two things: the number of patients you have and the patients which you and your embryologist have. I always say that the moment the embryologist realizes that, the moment the surgeon says, is it enough? The embryologist will say, ek aur sample bhej dijiye. And the moment he says, mil gaya, and you would say, band karu, he would say, usi ilake se thode aur bhej dijiye. So it's a beautiful thing, because ultimately at the end of the day, the story is getting children from these patients. Now, I'll also tell you about some post-operative management. 24 hours, I don't give an ice pack. A few people give ice pack. You go to scrotal support. 7-day continued scrotal support. 3rd month, measure testosterone, especially in a patient who is intelligent enough. And 9 to 12 months, repeat the testosterone again. In case you need to do a repeat micro-TESE, it's ideal to wait for at least 6 to 7 months, not before that. Check the testosterone before doing a repeat. I've put this all together, what I would do, 0 to 3 months, 0 to 3, everything, but time is not permitting. Future is going to be a multi-photon microscope. The differentiation will be better. And of course, artificial intelligence may lead to intraoperative analysis, which could be better, laboratory enhancement, and detection accuracy. Well, the pregnancy outcomes after a long time of hard work is what probably you would get. And of course, complication rates are much less in obstructive, in micro-TESE. Cumulative birth rates are better, improvement is much. And in the end, if you start doing this work, it is magical. Thank you very much, sir. Thank you very much. Thank you very much, Gaurav. Thank you very much in the team to invite me. And if there is any question and the time permits, I would be...
The question will be later on.
Okay.
Yeah.
मैं जानता था मुझे यही कहोगे. Thank you very much, sir. Thank you very much, sir.
Thank you, Dr. Sunil Jindal.